Welcome and thank you for joining us today. I'm Anna Abrams and I'm a second-year pediatric emergency medicine fellow at Children's Hospital Colorado. Our group actually includes Dr. Jason Woods, also from Children's Colorado, Dr. Teresa Chan from McMaster University in Ontario, Dr. Joelle Simpson from Children's National in DC, Dr. Wendy Jo Wendt from Children's Wisconsin, and Dr. Catherine Dunn from Children's Mercy in Kansas City. We're going to talk today about the unique and useful roles serious games can play in medical education. We'll go through evidence, talk about key attributes of serious games, making them particularly useful for medical education, and then we'll show a few examples and we'll have some time for questions during the Q&A session. The authors have nothing to disclose.
Thank you very much, Anna. There's really increasing amounts of evidence that show that serious games can be used for teaching and learning in medical education. In 2012, there was a systematic review of serious games for medical education and surgical skills. And that one is by Graflin et al., which shows that even then, almost a decade before, serious games were being used to train both technical and non-technical skills in the surgical field. In 2018, Gorbanov et al. Found that in the systematic review of serious games in medical education, that there was mounting evidence that these games could be used and were quite effective. In emergency medicine, my team has been leading the development of a series of board games, the first one being the Gridlock board game, which we were able to find shows quite high fidelity when you actually play it with residents and attending physicians and nurses to show that the actual game platform itself conveys the teaching and learning points that learners should actually pick up about emergency department flow.
As the body of evidence supporting the effectiveness of serious games grows, games are being used increasingly in medical education. The combination of entertainment and competition keeps learners engaged and motivated. New ideas and strategies naturally surface with each round, which both aids critical thinking and maintains entertainment. Foundational concepts in medicine, such as teamwork, are inherently practiced in most games, while friendly competition drives improvement. Players must work together with their team, but are also given the opportunity to make autonomous decisions without the crutch of a supervisor. Trainees, especially in pediatric programs, tend to comment on a lack of autonomy throughout their training. Gamification gives learners more opportunities for simulated autonomy. So trainees also tend to comment on a lack of feedback given throughout training, and gamification provides a unique opportunity for immediate constructive feedback during and after participation. Objective feedback aimed at skill improvement can be provided repeatedly with opportunities for immediate repetitive training. This instantaneous feedback is invaluable in medical education, especially surrounding high-risk events. From resuscitations to mass casualty events, participants practice rapid decision-making under simulated stress without real-life consequences. Community hospitals and rural providers may especially benefit from practicing these high-risk skills and scenarios in an easily accessible format. These games are cheaper and require less materials than typical simulations. High-tech equipment, large amounts of space, and skilled technology operators are not required. And as Dr. Woods is going to mention, virtual games increase accessibility even more.
Thanks, Wendy. One additional and particularly timely benefit of serious games is that many of them can easily be adapted for virtual use. Many of us have been challenged to provide equivalent education opportunities during the COVID-19 pandemic as we would have before. The inability to gather in groups in person have forced some innovation and pushed the use of serious games. There are several areas where, even after the pandemic ends, we can continue to use these principles. Outreach to rural learners, community hospitals, and even local EMS is a huge opportunity. Rather than needing to transport either the learners to the teachers or vice versa, which historically has been very costly, a single education team can reach learners scattered geographically anywhere they can access the internet. This is not solely a benefit of serious games, but many of the activities we think of as being easily adapted to virtual learning, such as simulation, readily make use of gamification. To list just a few examples, the website Virtual Recess Room makes use of Google Slides to create a top-down visual of a resuscitation room. Any number of participants can take different roles and simulate either pre-made cases or ones the individual facilitators create. The Virtual Recess Room website and the demonstration that I was able to take part in does not specifically call out serious gaming principles, but these would easily be applied. A scoring system which uses either time and adds and subtracts seconds based on errors, or uses a completeness scale would easily be added to this to give it the scoring and competition type feel that we all have come to expect from games. Outside of the virtual realm, serious games in the form of board games and tabletop exercises have already been implemented, and we have some examples today.
Thanks, Jason. So mass casualty events are infrequent, but optimal management of these situations is imperative to save lives. And this is a simple disaster tabletop exercise that has been used on numerous different learner groups, including pediatric residents, pediatric emergency medicine fellows, hospitalists, and community pediatricians and medical students. So a large layout is placed on a table showing a community hospital ED like we've shown here. And you can see rooms with a slash represent occupied rooms. There's a radiology suite, a waiting room, etc. And the group is given minimal information about an unfolding mass casualty event, such as a bus accident. They're given a few cards, each with a resource such as a nurse or a ventilator, and told they have a few minutes to organize before the patients arrive. Cards with patients, such as the ones you can see in this picture, can be handed to a group slowly or quickly, depending on the degree of stress the facilitator wants to simulate and how well the group is managing their current patients. The group then moves patients and resource cards around the ED layout, making decisions in a mass casualty mindset. More resource cards are given to the team when they're specifically asked for, and the game is extremely adaptable in terms of how long it lasts, how complicated its decisions are, how much it focuses on medical management versus resource management, and a lot more. So in reference to Dr. Wood's comments, it can also be played virtually in our current pandemic environment and as a means of outreach. And on the other end of that spectrum is Dr. Teresa Chan, who's made an official gridlocked game that she'll talk about now.
So everyone can see behind me a screen capture of us playing the Gridlock board game, which all of us, as vaccination rates go up, are probably excited to give it a shot again later on. It's a game that allows us to do teaching around flow in the emergency department in a low-risk situation, so that our junior learners who might not really understand and be able to see the whole board and understand the ebbs and flows of patient care can actually get engaged at an earlier time. There are even lesson plans that are available for the Gridlock board game because each of the cards are numbered at emsimcases.com. So free and open access resources for you to use when you're teaching this game.
Those are just a few of the examples that we know of already in existence, but in conclusion, serious games and gamification concepts have the potential to complement traditional education approaches and also allow deliberate, repetitive practice of skills and events which are otherwise really difficult to replicate. Serious games are cost-effective, they're engaging and adaptable to different groups of learners, and while games have long been used to hone procedural skills, more recently serious games have been applied to concepts like disaster preparedness to hone critical thinking and clinical decision-making skills. Trainees are able to practice thinking through high-stress, high-risk events while receiving real-time feedback. This provides valuable exposure to otherwise rare events without jeopardizing patient safety. Not only is this valuable for trainees like fellows, residents, medical students, but these concepts, like we mentioned, are extremely valuable when applied to community outreach efforts. Our examples today are original games. However, just like Jeopardy is often used to cover board review topics, existing games can be modified to fit specific objectives. Maybe Clue can become a clinical diagnosis mystery, or Candyland becomes a race to stabilize a patient. There are a lot of fun, creative, and effective opportunities within serious games, so everybody has a chance to play. Thank you so much for your attention, and we'd be happy to take any questions during the Q&A session.
Hi everyone, my name is Saj Ram. I'm a resident at UAB, and today I'm presenting Incident Command System, the game. Last year, while I was a medical student at Jefferson, I took the Wilderness Medicine course, which was virtual, unfortunately, because of COVID, but both Dr. Padaki and Dr. Phillips had come up with a creative way to learn ICS through Zoom. Because of them, I was inspired to do a board game that would also teach ICS in a way that's just a little different than usual. The goal of the game is to save all victims of a mass casualty with a team. The way it's done is you draw a scenario card, which tells you where victims and obstacles are on the board. Then, together with your teammates, you bring out your triage pieces and appropriately triage each victim. With transport and medic pieces, you treat the victims and bring them back to a treatment tent, and then out to a hospital. The point of the game is for anyone playing to get a better sense of the SALT triage algorithm, as well as also getting a general understanding of ICS. Setting up the game is simple. First, you draw a scenario card. In this case, it's avalanche. It'll tell you what victim cards to pick. In this case, it's 6 random cards from 1 to 15 and then 31 to 34. It will also tell you which obstacles to pick. You place those down on the board. The victim cards are placed face down in the location told on the scenario card. And then you have to place an ICS post. This is where your pieces are going to be leaving from. And a treatment tent. This is where the victims are going to be brought to. You want to put them in a strategic location that's easy for you to access all the victims and make sure that they can get back quickly and safely. Now to play the game. Once you've set up the board, you and your teammates take turn rolling the die. You each have a triage piece, a medic piece, and a transport piece. Let's say I start and I roll a 3. I put my triage piece on the ICS post and move him 3 spaces. Let's say in 3 spaces he manages to get to a face down victim card, turn over the card, and we label that victim. It can either be blue, unsalvageable, red, needing urgent immediate care, yellow, someone that's sick but has a little bit of time, and then green, someone that overall isn't as injured or as sick as the other victims. Then the other players also take turns rolling the die and moving their triage pieces and appropriate pieces towards victim cards. Often, once you've unveiled all the different victims, then you start heading out with your medic pieces and transport pieces to the appropriate victims, the ones that need the attention most quickly. You have to get past all the obstacles, get to the victim, and transport them back to the treatment tent. Once you're at the treatment tent, you roll the die, and let's say it's a red victim, and you have to roll the die of a 4 or greater in order to get them out of that tent. The tent can only have 4 victims at a time. Now, there's a time limit. In this case, for the avalanche, it was a 15-minute time limit. You also have a roll limit, where red victims turn to blue and where yellow victims turn to red. If, let's say, the roll limit is 40, that means if you collectively with your teammates have rolled 40 times or more, all the red victims that haven't made it to the treatment tent now become deceased. And let's say the roll limit for yellow to red is 80, now all the victims that are yellow that haven't made it to the treatment tent or received treatment now turn red. In order to win the game, you need to get all the victims to the treatment tent and out to the hospital within the selected time limit, without any of the victims dying, other than obviously the ones that were already blue from the beginning. Decided to make some variations of the game as well, just to keep the game a little more interesting. One of them is easy mode. This is when you're starting off, even if a red victim dies or you run out of time, you can keep playing. It's just to get a sense of the game. We also did competing players, where you're pretty much competing against the other players you're playing against, rather than working as a team. You have to get your set of victims back to the treatment tent before them. Obstacle extravaganza, essentially you just put as many obstacles as you want, makes the game a little bit harder. Limited resources, this pretty much changes the amount of victims you can bring in your transport piece, as well as a few other adjustments. And random victims, this is where you pretty much just put random victims face down in the allotted spots, and this can lead to either an easier game, because you might get a bunch of green victims, or a harder game, because you get a bunch of red victims. Afterwards, I'm happy to tell you a little bit more about the easy and medium hard mode and a 100-point rally, because those just take a little bit more time to explain. Our goal for the upcoming year is to optimize the game and distribute it. We want to send it out to different wilderness electives to see if it's a good way for students and anyone on those electives to understand ICS before going out on the field. We want to get their feedback and change up the game in a way that it's better for learning and more fun to play. If it becomes really fun and people really enjoy it, we hope to expand it to a larger audience and hopefully inspire people to go into medicine and emergency medicine, wilderness medicine, and just make a big difference in the world. Thank you all for listening. I wouldn't have been able to do this game without the help of a lot of different people. One of them is Gabby. She helped to design the game and do the instructions and played a really big part in creating the game. Tamar, she was working with the Jefferson Health Design Lab, and she's also been essential in helping create the actual pieces for the board game, playing the game, along with Caitlin and Luis, who were able to say, hey, this scenario needs to be changed up, or the game should be played this way, and they played a big role in really forming this game. And then a big thanks to both Dr. Padaki and Dr. Phillips, who saw the game, really liked it, and encouraged us to work on this game to hopefully distribute to everyone and make it a really good learning experience. Thank you again.
The management of dislocation reductions is a crucial aspect of comprehensive training within emergency medicine. Due to the COVID-19 pandemic, however, local governments have implemented policies restricting many activities, resulting in fewer orthopedic injuries and traumatic presentations within emergency departments. As a result, there is a lower incidence of polytrauma, fractures, and joint dislocations. Due to decreases in patient volume and fewer opportunities to perform dislocation reductions, we developed a series of models and orthopedic curriculum to supplement exposure to these procedures. Through the implementation of joint dislocation models, resident physicians may attain procedural competency, practice reduction techniques, and help to satisfy ACGME requirements despite the relative scarcity of dislocations.
Similarly to other critical procedures that are already perfected through hands-on educational sessions such as casting and splinting, procedural competency in joint dislocation reductions would benefit from a hands-on approach to training.
My name is Richard Shin. I'm the simulation director here at New York Presbyterian Queens. We utilize low-cost, high-fidelity, reusable, and wearable models utilizing open access 3D printed files. We utilize models which include the elbow, shoulder, knee, ankle, and jaw. And these were further assembled using additional materials into functional joints that allow for assessment of appropriate traction and tactile feedback for successful reduction. These have been supplemented with an orthopedic curriculum for comprehensive learning of joint reductions. We sourced many of our 3D printer files from thingiverse.com, and we utilized free software for 3D printing, including Slicer and Ultimaker Cura. The total cost of our 3D printer was $250 and an additional $50 for the cost of our material. We utilized white PLA plastic in order to create these models, and some models, including the femur, were too large for our 3D printed platform, so we printed them in pieces and bonded them together, utilizing epoxy or heat. We found that because these models were wearable, they enhanced our emergency medicine resident education. We were able to make our education sessions interactive and allowed us to use rapid cycle delivery practice in order to reinforce the techniques for a successful joint reduction.
With our advent of these simulation models, we have had immense improvement in our residents' abilities to perform these procedures. With this, we're not only able to improve our patient care, but we're also able to improve our resident education from interns, second years, and third years. Traditionally, we would have taught our residents how to reduce joint dislocations just by videos and teaching on co-learners. However, of course, you can't dislocate each other's joints just for fun and for practice, so we've been able to do this with our joint models. And this really is the best way to feel when a joint is dislocated, how to perform the reduction technique, and when to confirm that it's realigned and reduced.
In terms of anatomic size and the bony prominences, it really helps to give me kind of an anticipation on what to expect for a real reduction. Nothing beats actual practice, so I think that being able to just like physically manipulate these models and just know what to anticipate is really helpful.
I think with some of the dislocations that I'm less familiar with, like knee and elbow, the opportunity to perform it in sim is great because it allows me to really practice and feel comfortable about seeing a patient even for the first time, to have a good idea of what should and shouldn't be done, and then also to know how things should feel and whether I'm doing something correctly or not.
So I think it's very nice to actually use these models to practice these shoulder dislocations, especially since first time around, it's not necessarily the easiest thing. And then actually seeing the anatomy using these models, it's more easier to reflect on the actual techniques that we're doing and how they actually work in reducing the shoulder.
It would be great to be able to incorporate all of these bone models into our simulations during our weekly conferences, just so that we get more frequent exposure to them. I mean, I think being able to put our hands on things and to do it with a physical model, especially when it's connected to you, is very helpful, especially in visualizing the anatomy and just being able to do it with our hands instead of watching videos and hoping for the best. Oftentimes there are like lots of different ways to perform like the same procedure, and I think like the ability to know a lot of different ways and like to have that in the toolbox is actually really helpful.
I've had a lot of experience pre and post with these joint models, and beforehand I taught myself, learned on YouTube, and did practice on a number of patients in the clinic, during my fellowship in sports medicine, and also on the sidelines where we would reduce shoulders that would come out during obstacle course races and such. I haven't found a better simulation or a better substitute for this type of procedure. These models really provide the best visual and tactile response when you are performing the dislocation reduction. So I would definitely recommend this for all curriculum directors out there, for orthopedics, for residency programs, and even physicians and providers who are out in practice who need to get more experience with their dislocation reductions.
Picture this. You are locked in a room with your friends and have to figure out clues to get out of the room. Now imagine that you are timed and challenging a group of your peers to see who can get out or escape the room the fastest. Now let's make this room medical and use medical trivia and educational learning points. And finally, let's make it virtual. And now you've gone through my creation process. I want you to compare blank Zoom screens watching an hour-long PowerPoint to active participation and friendly competition, which leads to the idea of gamification of education. The gamification theory in education is that learners learn best when they are also having fun. Not only this, they also learn best when they have goals, targets, and achievements to reach for, of course, in a way that the learner still perceives as fun. Can you escape traditional learning? This presentation by Cassandra Mackey, Alexandra Nordberg, Richard Church from the University of Massachusetts Medical School. In this brief presentation, I'm going to describe how to create a virtual escape room to provide active learning for residents, students, or other learners. We have no financial disclosures. The first idea I want to explain is the general concept of escape rooms. You have a specific amount of time to solve the clues in the room. The clues allow you to unlock the numerical locks, key locks, directional locks, or alphabetical locks. When you unlock, you are led to more clues until finally you unlock the final lock and escape out of the room. Step 1 to creating a room is to determine the goals and objectives. As with any good presentation or activity, what do you want the residents, students, fellows, or faculty to learn? What do you want the learners to take away from your room? Based off of the learning objectives, map out the questions you are going to use and the locks that need to be solved. In this case, there's a blue, light blue, yellow, and red lock, which get to the final lock, the green lock. Now you're ready to create the room. Pick a picture as the main room background using Google PowerPoint and add in items. You can put hyperlinks to each added item. To add a hyperlink to the stethoscope, as shown, simply click the logo, the chains or the links above the blue arrow on the screen, and then add in your hyperlink. Hyperlinks can be to questions or locks using the Google Forms function. Only way to get the clue is to answer the multiple choice question correctly or the lock correctly. I used multiple choice board review questions. When you answered those correctly, you were given various clues when joined together to solve the locks. The locks were created using the text questions, so there was only one way to get the right answers. Solving the locks also leads to clues to open more locks until you open the final lock, the door lock, in my escape room. This is what solving a lock incorrectly, the picture on the left, incorrectly, the image on the right, looks like. When it's correct, it moves on to the next section, which is a clue to help you move forward through the room. Incorrect answers do not lead you to the next clue. The final escape is getting through the door lock. Here's an example of a finished virtual escape room. The topic for this one is ophthalmology. The locks in this case were the Woods lamp, the tonopen, and the ophthalmoscope. Please feel free to reach out to me if you would like a link to this room to see how the room works. On the day of presenting the Zoom escape room, split the participants up into Zoom breakout rooms and have one person share their screen per breakout room. This person will be driving the group through the escape room as the group leader. Initial data is promising. People who have participated enjoyed the experience and would do it again. Of all the people surveyed, which is a mix from interns to attendings, 79% recommended this format for future lectures. The legend on the right shows the different numerical options from strongly disagree to strongly agree on a scale of 1 to 5. 79% of respondents strongly agreed that they enjoyed the activity, and 21% agreed that they enjoyed the activity. 91% of respondents learned something new during this activity. Ideas for the future include creating a website with multiple different rooms based on topics for resident self-study or group study. For instance, if a student or resident wanted to review information on the eye, they could click one of the doors. Or if they wanted to study a different topic, they could click a different door. Any questions? My email and Twitter handle are at the bottom right of the screen. Please feel free to reach out. Thank you for your attention.
Hello, my name is Lauren Walter. I'm an APD at the University of Alabama at Birmingham, and I'm here to talk to you today about our opioid use disorder tabletop simulation, an immersion experience to increase empathy and awareness of stigma. No disclosures to make. So while as a subspecialty, emergency medicine has increasingly embraced the essential role of addressing the needs of patients presenting with opioid use disorder, most EM physicians remain inadequately prepared to identify and manage this population. The opioid epidemic has outpaced EM residency education, resulting in a critical gap. And unfortunately, the pandemic has exacerbated the opioid epidemic. A December 2020 press release from the CDC highlighted the significant increase in overdose deaths across the nation, greater than 20% in Alabama, and greater than 30% in Jefferson County, Alabama, the home of UAB, further highlighting the need for expansive efforts, including from the emergency department. An additional hurdle to the management of patients with OUD includes negative and positive attitudinal regards toward a traditionally stigmatized patient group. Several previous studies have highlighted the impact and weight of stigma associated with OUD. Creating OUD competent and sensitive EM physicians will require incorporating OUD education and stigma training into EM residency. And so our objectives with this curricular innovation were to, one, demonstrate feasibility and acceptability of OUD education via delivery of an opioid tabletop simulation, and to improve awareness of stigma and increase empathy for OUD patients. So the Office of Interprofessional Simulation at UAB has developed an opioid tabletop simulation. It's a 2-hour immersive tabletop simulation experience that we delivered to 15 emergency medicine residents and 3 additional core educational faculty as part of a comprehensive OUD didactic day. The opioid simulation is an experiential tool which helps learners understand that opioid use disorder is a chronic disease for which there is treatment and recovery, experience the role of stigma and the disease of addiction, and understand how resiliency can impact people with this disease. Presented in a board game-like format, the simulation personalizes the experience for participants of navigating life with addiction, being a healthcare provider responsible for making choices about resources in a resource-limited environment, and being a clinician providing care for people in active addiction and in recovery. Participants were evaluated via the Perceived Stigma of Addiction Scale, or the PSAS, an 8-item scale intended to measure perceived stigma towards substance misuse, immediately prior and subsequent to the intervention. General course feedback was also solicited. The Perceived Stigma and Addiction Scale was developed by a PhD psychologist. This is the first 4 questions of the PSAS for demonstration. There are 8 total. This scale provides a single total score. 6 of the questions are reverse scored if you're counting. The scale total score ranges from 8 to 32, with higher scores indicating greater perceived stigma or sensitivity to the impact of stigma on individuals with substance use. This is an overhead visual of the tabletop sim. Again, it's delivered in a traditional sim model, including a fictional contract, pre and post debriefs. However, it occurs in a board game-like format. There are 3 roles randomly assigned, including 1 medical provider, 1 rehab intake counselor, and 4 to 6 individuals with OUD. Individuals or players with OUD are provided with unique, brief bio backgrounds, and then they must navigate the board as they would life. Of course, the goal is sustained recovery, but medical encounters, life hazards and exposures, and medical knowledge building experiences are encountered along the way. Again, we had 18 participants, including 15 EM residents, complete the opioid simulation and the pre-post PSAS. Again, a higher score on the PSAS indicates greater awareness of and sensitivity toward the stigma associated with substance abuse. There was a statistically significant difference between the average stigma scores pre and post-intervention. Specifically, there was a lower average score of stigma for participants pre-intervention with a mean of about 19, compared with post-intervention where there was a mean of 20. The p-value here was 0.04. All respondents providing course feedback felt the simulation was a meaningful component of the didactic day. Participants' perceived stigma related to opioid use disorder increased significantly, indicating that the use of tabletop simulation increased awareness of the prevalence of stigmatizing attitudes and actions in society with specific regard to opioid use disorder. Our future projects and considerations are primarily currently aimed at the development and pilot of an EM-specific simulation which incorporates buprenorphine and other clinical elements unique to the ED. In addition, assessing the potential long-term attitudinal and clinical impacts of engagement in this type of simulation will be focus of future assessments as well. Thank you so much for your time, and I look forward to answering any questions that you might have.
Hey everyone, I'm Mike Terciano. I'm an emergency doc in Maimonides Medical Center in Brooklyn. Today I'm talking about our work entitled Simulated Goals of Care Conversation Training Builds Communication Skills in Emergency Medicine Attending Physicians. So a little bit of background before we get started into the project. Patients with serious illness and their loved ones turn to the ED in times of crisis. By patients with serious illness, I mean people with end-stage frailty, dementia, end-stage cancer, end-stage organ failure. And when these patients present critically ill, it's a particular challenge for the emergency doctor because we need to figure out what to do for these patients by aligning with their families and the patient to determine the best course of care, because we know a lot of these patients may not want our default setting, which is aggressive, invasive medical care. To do this effectively and figure out what patients want, we need to have goals of care conversations in the emergency department. But we know they're hard to have in the ED. This is due to the clinical complexity of these patients, lack of time, lack of space, lack of longitudinal relationships. But despite these obstacles, communication skills around goals of care conversations are an essential competency for emergency physicians. But despite this, most emergency doctors have had no formal training in this domain. So we sought to develop an interactive educational module to close this educational gap around goals of care conversations in the emergency department and among emergency department physicians. To do this, we designed a simulation curriculum that set out to do a couple things: discuss barriers to effective communication in the ED, introduce and practice with an organized framework for having goals of care conversations, and then incorporate these new skills into our daily clinical practice. So to do this, we gathered a cohort of our EM attending colleagues. We basically built this project into our normal faculty development curriculum, which meets weekly in small groups. It was done at our urban academic center with our ACGME accredited residency program. We broke up into groups. Each group came once, 3 to 6 learners, and we had them for about 2.5 hours. Subjects completed a pre and post course survey probing attitudes around goals of care conversations in the ED. The day was broken down as follows. We had 45 minutes of didactics. We explored difficulties around end-of-life communication in the ED. And part of this, we introduced a novel goals of care conversation framework recently published in the Annals of Emergency Medicine that's designed by an ED doc. It's meant to be used at the bedside, sort of a real-time reference or checklist that you can use clinically in the moment. And after going over this conversation guide, we did 2 high-fidelity simulations with trained, standardized patients. We used 2 unique cases, sort of borrowed from some folks at NYU who gracefully lent us their cases. And we went through the cases in front of the group with a SP, a standardized patient, and a facilitator. And part of the rules of this sim is you could stop and start the case whenever you wanted. The facilitator could also do the same. This is a technique we adapted from the Vital Talk group, who does palliative care conversation training all over the country. And this really allowed us to explore particular conversational challenges, highlight good things, rewind the case, start over if needed. This really allowed for deliberate practice. We then consolidated our learning during debriefing sessions. Open-ended responses. So for the outcomes, we looked at the open-ended responses and found that there was improved confidence using a structured approach to goals of care conversations, and recognize an increased recognition in the benefits of active listening. We also found that patients became more comfortable, our participants became more comfortable making recommendations during goals of care conversations. And 90% of participants found it was either quite or extremely effective in introducing effective goals of care conversation strategies and teaching skills for navigating patient and family emotions. So what we found is that to address the challenge of seriously ill patients and determining what they need at times of crisis in the emergency departments need to learn to have end of life care conversations. We have a lack of training, and because we're not comfortable having these conversations, we default to aggressive care. And as a result of our own shortcomings, we fail to role model best practices for trainees. We found that simulation-based training allowed us to introduce a novel conversation guide, and our simulation strategy allowed for real-time debriefing and a sort of low-stakes environment for deliberate practice. We found improvements in active listening, improvements in using emotional data, and offering clinical recommendations based on patient values. This was a novel program for us, and I think we're going to try to broaden it out to incorporate the residents and the nurses and make it an ongoing thing to really hone this skill. I just wanted to take some time to thank the Maimonides Simulation Center, Dr. Kai Uchi, who put together the conversation guide that we used in our training, and Drs. Karita Grutzen and Audrey Tan from NYU. Both ED docs are doing amazing stuff with palliative care. They shared the cases with us that we were able to adapt. And finally, I'd like to thank Vital Talk. I took their course. It was very helpful in developing our simulation strategy. Please shoot me an email at mterciano@maimonidesmed.org with any questions, and thank you for your time.